All right, let's see what we can get through for peds ortho here. All right, skeletal system defects. Oh, there we go. We have congenital talipes equinovarus, or clubfoot. It's more commonly known as clubfoot. It's a deformity where the foot is inverted, so the heel is drawn up and the forefoot is adducted. So hopefully you guys remember what adducted is. It is the most common congenital foot deformity. It is easily detected in a newborn. However, one of the biggest things is that it must be differentiated from a persisting position of comfort, which is acquired in utero. So sometimes the babies just kind of sit in a certain position and their feet kind of go in just from positioning. So you have to make sure that this is a true clubbed foot versus a in utero positioning with the foot. It is easily corrected if detected in the neonatal period with manipulation and bandaging or application of a cast. Force is never to be used. Let's see. A hereditary factor is observed occasionally. It occurs in 1 of every 1,000 births. Can be bilateral or unilateral, so both foot can be affected or only one foot can be affected. If casting is needed, it is usually done right in the nursery, right after birth. Casts are changed every few days for several weeks and then every week or two until the x-ray confirms complete correction. Any cast should have some type of waterproof material protecting the skin from the sharp plaster edges, and they call that pedaling. So to pedal a cast, strips of adhesive are cut 2 to 3 inches long and about 1 inch wide. One end is notched and the other end is pointed. So the strips of adhesive are then applied vertically around the edges of the cast. And this is known as pedaling. And I think I've got a picture for you. But it's especially important for pediatric patients because they can't talk to you and tell you what's wrong. They can't tell you if anything is poking them from the cast, digging into their leg or anything. So here's a picture of true club foot. And this is very common to have what we call positional in utero deformities where the feet look like this, but they're not inverted nearly as much as this. All right, so here's casting for clubfoot done very early on. All right, then we've got congenital hip dysplasia. This is more common in females. It results from defective development of the acetabulum with or without dislocation of the hip. For successful correction, early identification and treatment before the infant starts standing or walking is very important. So the first exam is during their initial newborn exam. So as soon as babies are born, the pediatrician comes in, assesses the infant, and one of the things that they check for is congenital hip dysplasia immediately. Practitioners may hear an audible click when using Barlow's sign and Ortolani's maneuver. Now you're going to need to know Barlow's and Ortolani's, what they are, how they work, and the age range. So you're going to use Barlow's and Ortolani's maneuver for an infant before 1 month of age. Okay, after 1 month of age, these are not reliable indicators. So Barlow's and Ortolani's maneuver, Barlow's sign and Ortolani's maneuver are done on infants less than 1 month of age to diagnose congenital hip dysplasia. So these are in the book, but Barlow's sign is when you adduct the hip, so you bring it in towards the midline while applying a light pressure to the knee. And if the hip dislocates, then the test is positive. So they often, I'm going to show you a picture here, but they feel like this, and so they have this part of their hand on the hip, and this is where their knee goes, the baby's knee, and so they will adduct, and then they can feel right here with their fingertips if the hip comes out of joint. So they're grabbing the knees here and they adduct them and they can feel if they dislocate. And then Ortolani's is when they flex the hip knee of the supine infant in to a 90-degree angle. Then pressure is applied to the greater trochanter while the leg is abducted. And if a click is heard, then the test is positive. So be sure that you look those up and know which is which, how it works, what it tests for. and that you want to do that. That's really only diagnostic less than 1 month of age, or within the first month of life. After the first month, when the click disappears, other symptoms include, on page 334, hopefully you're going to pause the video and take the time to look this up. Again, you'll learn it a lot better. But in case you don't, after the first month, you will notice asymmetry of the gluteal skin folds. It'll be higher on the affected side. This is on figure 14.9b in the book. Limited abduction of the affected hip. This is figure 14.9a. If a dislocation is present, the affected side cannot be abducted greater than 45 degrees. And then you have an apparent shortening of the femur. This is figure 14.9c in the book. Okay, so these are all going to be signs after 1 month of age. So here's ortolani's. Like I was telling you here, they grab right here. They're using their fingertips to feel if they feel any kind of clicking or any dislocation going on. When they do, oh, I don't have Barlow's. Barlow's is very similar. Well, it's just like this, a downward pressure and an in, but the fingertips are down here and they can feel it dislocating. Next, we've got the gluteal folds. Now remember, the uneven gluteal folds are going to be after 1 month of age. And you can see the difference here. Okay, over here, no folds. Over here, we've got multiple folds and these uneven gluteal folds here. All right, here's an infant with some uneven gluteal folds. See how this one goes so far up? This one's just right here. Then we've got these. We've got extra folds here. These aren't the same. These are not the same. Not the same. Okay. After the child has started walking, so we have different signs. We have signs for 1 month within the first month, signs for after a month of age, and then signs for after the child has started walking. So after the child has started walking, later signs are going to include things like lordosis, sway back, protruding abdomen, shortened extremity, a waddle-like gait, and a positive Trendelenburg sign. So Trendelenburg's, if you don't know Trendelenburg sign, hopefully you all know Trendelenburg for the bed. When you put a patient in Trendelenburg's, when you take them like this, head to bed, all the way down. But a Trendelenburg sign for congenital hip dysplasia in children who are walking is when you have the child stand on the affected leg and raise the normal leg. And when this happens, the pelvis will drop. Okay? The shift of gravity will happen to reduce the load of the amount, the load amount on the standing leg. All right? Correction is started during the newborn period. They can do what they do, double diapering. So they put several cloth diapers on the baby to hold the legs in an abducted position, in a frog-like position, which will allow for normal development of the joint. Oftentimes we don't really double diaper anymore, but we can. This is a way that we can help for a mild hip dysplasia. We can also do a Pavlik harness, which is the most common type of brace and aligns the femur gradually. If an uncorrected dislocation causes limping, easy fatigue, hip and low back pain, and postural deformities. So if treatment is delayed until after the child is walking, or if earlier treatment was ineffective, an open reduction followed by application of a spica cast may be needed, which covers the lower body from the waist down, leaving only the feet open, and the cast maintains the legs in a frog-like position. Pretty sure there are some pictures in your book of a spica cast, but I'm also going to show you some pictures here. And then as far as nursing goes, you're doing an assessment of whatever treatment option is being used. So providing comfort measures, promoting skin integrity. If there's casting, make sure we've done the pedaling. Promoting sensory stimulation, providing family teaching is huge. That information is on page 336 in your book. All right, so here's a Pavlik harness. Keeps them in this frog-like position. We used to put these on babies like right after birth if we suspected congenital hip dysplasia. Honestly, in the past several years, we have not done this very often initially, but this is still used very frequently for treating congenital hip dislocations I have a friend who works at Shriners, and so I was asking her, do you all still do this? We used to do it all the time. Now we don't anymore. And she was like, oh yeah, we still use a lot of Pavlik harnesses. So here's the Pavlik harness and the spica casting. This is a short leg hip spica casting. Can you imagine how difficult it would be to keep that clean? It's very difficult to keep a Pavlik harness clean. And they have to stay in this for most of the day. There's only like a very few hour or two that they're allowed to be out of the harness in order for the treatment to work effectively. In fact, I just had an acquaintance that, someone I just knew kind of in passing, whose daughter had to have a Pavlik harness placed for some hip dislocation. And then here's your normal pediatric hip in the cross section. Here's your congenital hip dysplasia. So you can see here's your normal hip. Here's your congenital hip dysplasia. Easier to see in the cross section here. So you can see how the ball and socket fits together. And you can see here it's not together at all. All right, childhood fractures. This would be your green stick fracture. All right, musculoskeletal disorders. Fractures are the most common in children. The most common ones are clavicles, femurs, tibias, humerus, wrist, and fingers. Fractures in children heal more quickly, are less complicated, and have different causes than adults with fractures. Fractures in the area of the epiphyseal plates can cause permanent damage and can impair the growth, kind of stunt their growth. If you'll remember, the epiphyseal plate is the growth plate in children, and that's why that's so important. Green stick fractures are more common in children because they have soft bones. And I've already told you that story of my sister when she jumped out of the car when she was 3 and the car rolled over and nothing happened. Spiral fractures may indicate abuse due to the twisting nature of the extremities, and there's pictures, I think, on page 559. All right, so here are some epiphyseal fractures. Here's your normal bone, a complete physeal fracture with or without displacement. I mean, there's different, I don't necessarily expect you to know the types, but just know that there are different fractures that can occur there at the epiphyseal plate, which can affect growth of the bone. Here's your green stick fracture, so it fractures on one side and does not go all the way through. Here's your epiphyseal plate, so here's your fracture that goes across the growth plate. All right, as with all fractures, there is a risk for compartment syndrome. You need to monitor neurovascular status by observing and documenting and reporting your 5 Ps. Hopefully you guys remember the 5 Ps. Please look that up if you don't remember what those are. You're going to assess for signs of infection. How are we going to assess for signs of infection? Hopefully you remember, you're going to check for heat, redness, increased swelling, fever, foul odor, drainage, anything like that. Education on never putting things inside of a cast, no matter how bad the area is itching. And this is very important for children because kids stick everything everywhere, okay? Legos, they'll put Legos down in their casts. They'll put toys down in their casts. And they may not tell you because they may be afraid that they're going to get in trouble, but it can cause severe, many more complications. So if you really think about it, if you've got something stuck down in a cast and that cast is going to be on there for weeks, it's going to it can severely damage the skin and actually cause an infection and grow into the skin, and just, the muscle will deteriorate. It can just cause a myriad of complications. So you need to watch that pretty carefully. So children are really upset, crying quite a bit over something with the cast, then you need to investigate that a little bit further. All right, you need to do education on cast removal. What was it? Hopefully you remember we talked about cast removal, that they do that cast saw. How long does it take for the fracture to heal typically? What do they have to do after they get a cast off? Remember, they've got to soak the skin and get that dead skin off of there. If a child's in traction, weights should be hanging freely and not touching the floor because children tend to slide down in the bed. Be sure that you look in Leafer, page 565, Care Plan 24-1 talks about that. All right. Pediatric musculoskeletal disorders. Muscular dystrophy. Muscular dystrophy is a hereditary, progressive, degenerative disease of the muscles. The most common form of muscular dystrophy is Duchenne's muscular dystrophy. It is X-linked. It is most common in males. Females are carriers of this disease, but the children that actually have the disease are more often males. You test both the mother and the father when a child is diagnosed. Okay, so here's your healthy father, here's your healthy carrier mother, but it is an X-linked issue. And so you have your healthy son, your healthy daughter who's a non-carrier, your healthy daughter who's a carrier, and your son with Duchenne's. Okay. Clinical manifestations and diagnoses. First signs are usually during childhood. Usually within the first 3 to 4 years of life, parents start noticing some issues. The child has difficulty standing and walking. They can't rise easily. They have to do what they call a climbing. So they kind of climb up their lower extremities to stand upright. Excuse me. The later stages include trunk muscle weakness. The child has lordosis, pelvic waddling, and frequent falls. They are usually wheelchair bound by the age of 10. The lifespan of this child is usually early adulthood, and they have death related to what would you suspect based on the findings that I've given you up here. Okay, hopefully you realize that they start having trunk muscle weakness, lordosis, they're going to be wheelchair bound. This early adulthood lifespan is usually due to death from respiratory failure or heart failure. All right, a muscle biopsy will confirm the diagnosis. Here's your child doing this climbing up the lower body. So to stand up, they literally have to climb up their legs to be able to stand upright. They're just that weak. All right, here's your normal bicep, and here's your bicep with muscular dystrophy. So it's pretty significant changes. Make sure that you understand those differences, or what the signs and symptoms that you would notice, how they would present. All right, treatment for muscular dystrophy. There is absolutely no effective treatment. The child is encouraged to be active as possible to delay muscle atrophy and contractures. Diet to avoid obesity, since they're not as mobile. But absolutely nothing prevents the progression of this disease. The disease will progress, but you still want to encourage activity to delay the muscle atrophy that's going to occur and the contractures. When the child becomes wheelchair bound, a kyphosis develops and causes a decrease in respiratory function. Hopefully you remember which one is lordosis, which one is kyphosis. Causes decreased respiratory function and increases the risk for infection. Breathing exercises are then going to be needed for sure on a daily basis, the incentive spirometer, and things like that, to try to really get them to expand their lungs, and that will be work for them to do that. So how do you educate this family? You're going to advise the family. Hopefully you're going to stop the video right now and look this up in the book. But in case you don't, I'm still going to tell you the answers, but you'll get them you'll learn them better if you'll look them up. You're going to advise the family to keep the child's life as normal as possible. You're going to educate that the disease can drain the emotional and financial reserves of the family. You need to refer them to Muscular Dystrophy Association, refer them to support groups, and that it helps by talking to other families who have the same experiences. You're going to educate them on breathing exercises and different body exercises as well that they need to do. Now, one thing I wanted to mention just about support groups and advising them to seek out others who have children with muscular dystrophy is that's a huge factor. It's a huge help. I know when I had the twins, there is a group in town, I'm sure I know it's still going, Bluegrass Parents, the Twins and Multiples Club. And the first time or so I was kind of like, do I really have time to go to this group? But I wanted to kind of get involved, and so I went, And it was such a huge help just to hear other people talking about how things that they had already done, the situations they had already been in with their twins and multiples, and how they did it this way, and what worked for them, and what you might want to try. And it was eye-opening. It was eye-opening. And so just talking to other people who've been there and done that, when I then went back to work after the twins, I always tried to get the patients who were pregnant with twins and multiples, or who had just delivered twins and multiples, just because having that experience kind of puts you, just gives them someone to relate to and ask questions to. I mean, I could answer their questions, I could attempt to answer their questions even before I had the multiples, but having that experience really helps significantly. So that some things, sometimes people just kind of want to keep private and they don't want to seek out support groups, but really encouraging them to at least attend one or two to see if they, still feel that way would be very beneficial for parents with children with muscular dystrophy. All right, juvenile rheumatoid arthritis, JRA. It's an autoimmune disorder where the body identifies some of its own cells as foreign, and the immune system begins to attack healthy cells and tissues. Right, and juvenile rheumatoid arthritis is the most common connective tissue disease of childhood. The definition of the connective tissues are that they provide the supportive framework and protective covering for the body, things like skin, mucous membranes, musculoskeletal system. Okay, it peaks between 1 to 3 years of age and 8 to 12 years of age. 85% of children with juvenile rheumatoid arthritis will reach adulthood without any serious disability. Clinical manifestations, how is this going to present itself? Joint inflammation. If the joint inflammation is left untreated, inflammation leads to irreversible changes in the joint cartilage, ligaments, and menisci, which can lead to complete immobility. All right, there are 3 different types. We have systemic, polyauricular, and oligoarthritis. So systemic, hopefully you'll take time to look this up. But systemic will affect internal organs. It is characterized systemically by fever and rash. Polyarticular is poly would mean more. So polyarticular is involving 5 joints or more. And oligoarthritis, oligo would mean less, and that's involving 4 or less joints, usually the knees and ankles.